Good afternoon and welcome to today's webinar. My name is Jim Parker and I'm editor of Hospice News. We are here to talk about technology to navigate the COVID-19 pandemic. Hospices and other healthcare providers are ramping up their use of telehealth in order to help prevent the spread of COVID-19 during the ongoing crisis. Additionally, hospices have received new regulatory flexibilities regarding the use of telehealth, both through legislation such as the CARES Act, as well as actions by the U.S. Centers for Medicare and Medicaid Services. Next slide, please. Our objective for the webinar today is for attendees to learn about the many practical use cases in which virtual patient support technology enables clinicians to fulfill their calling even during times of crisis. Speaking today are Melissa Kozak, CEO and co-founder of Citus Health, and Sharon Harder, president of C3 Advisors. As a post-acute nurse in New York City for 8 years, Melissa saw firsthand the communication and care coordination challenges connecting frontline clinical teams with office teams and partners in home-based care. She also recognized that providers were relying on outdated technologies to communicate with family members and caregivers, causing unnecessary delays and decreasing quality of care. Melissa teamed up with a leading healthcare technologist and founded Citus Health in 2016 to tackle these challenges head-on by providing real-time, secure solutions that ensure a high level of care team coordination and family engagement. Next slide, please. Sharon Harder is the president of C3 Advisors, LLC, and she focuses her time exclusively on hospice and home health matters. She served in operational and financial roles in a variety of healthcare organizations, including a major national professional association and post-acute care providers. As president of C3, she engages with clients to help develop and implement strategic vision required to thrive in a complex regulatory setting. She is a nationally recognized author and speaker on hospice topics and is a recognized expert on hospice compliance. Following our presentation will be a question and answer session. Please feel free to submit questions in the designated box on the GoToWebinar app. Slides and a recording of this webinar will be sent to participants by email. And without further delay, I will turn this over to Sharon.
Well, thank you, Jim. And next slide, please. Melissa, it's really good to be working with you again. And welcome, everyone. We have a pretty packed agenda this afternoon, so I'm just going to get started. Our agenda is meant to establish the framework for changing practice patterns that have been introduced by the COVID-19 public health emergency, but which will likely be sustained over a much longer term. We're going to talk about how COVID-19 has affected Medicare patients, how hospice utilization has changed due to the pandemic, and how, by using virtual technology, hospice teams can bridge the emerging care gaps brought on by a need to minimize in-person visits without compromising the quality and effectiveness of care. Citus has developed technology that's tailored to fit that emerging need, and Melissa is going to show us some of that and how the virtual patient care can come with some significant benefits for patients, for their caregivers and family members, and for the hospice team caring for them as well. So with all of that as our framework for today's discussion, let's get started. Next slide, please. COVID-19 is having the most effect on Medicare beneficiaries located in 12 states. And here in this table, we investigate the top states where we can find COVID cases. Now, what really stands out here is that of this dozen states, 8 are among those in the top 10 for concentration of Medicare beneficiaries. So these are the states to watch in terms of post-acute care surges in general and hospice surges in particular that might occur between now and mid-May as hospital discharges peak. Now, I've been tracking these numbers for about 6 weeks now, since mid-March, and it's interesting that the standings in terms of concentration of COVID-19 cases have changed very little since the beginning, even though the number of cases has gone up very dramatically in that 6-week period. And for the record, these numbers are from the CDC, and their totals do lag some of the others by a little bit because of the way that they update their website. But in fact, what we know from reports as late as this morning, we now have gone past 1 million cases and 60,000 deaths from COVID-19 in the United States alone. So when we think about a surge of COVID hospital discharges, we've concluded that the post-acute peak for most states will occur between now and the middle of May. And this is going to be when patients are discharged from the hospital. They're going to come home and they're going to have expectations of receiving additional care at home. What we have to remember here is that COVID patients have a median hospital stay of somewhere between 10 and 13 days. So the majority of our top 12 states are going to peak somewhere in the neighborhood of between now and May 16th. But it's important to remember that these are our top 12 states. The peak points in other states are going to lag behind, and some could go through the middle of the month of June, perhaps even as late as late June. So here's the takeaway for hospice teams. As cases among the states peak, this will be a predictor of admission surges for patients who may have survived COVID-19, but who are left with significant cardiac or renal damage that could operate to hasten the trajectory of chronic illnesses that they may have had to their end stages. It may not mean that these patients come right out of the hospital and elect hospice. They may come out and they may not improve over a period of weeks or months, and then they elect end-of-life comfort care, pardon me, as they fail to fully recover from the damage that is wrought by this virus. And what we know now is that this virus behaves in ways that involve the whole body, not just the patient's respiratory system, but other major organs and systems. So we're going to be seeing some new and perhaps very complex problems among this patient population. Now, a clear challenge for hospice providers will be caring for patients who are hospitalized with a virus and advised early on, perhaps by inpatient palliative care teams, about the risks of intubation and ventilator placement. And some of these patients, especially those who are older with significant prior histories of cardiac or even respiratory illness, will be advised about end-of-life options and could elect hospice care in lieu of that vent based on guidance that they receive from the acute palliative care team about the risks versus the benefits of that vent. And for some of these patients, there may not be an immediate hospital discharge, even though the patient or his or her family elects hospice care. And in that case, in practical terms, we'll have a hospice patient who remains in the hospital for a period of time and for whom the hospice will be unable to provide in-person visits. But the hospice will still be obligated to provide some level of care. So we're going to have elderly patients with significantly advanced comorbid conditions who contract the virus and elect hospice rather than being placed on that vent. And some of you could see upswings in general inpatient care as a result of that. But as we'll discuss, there will be some care delivery challenges associated with some of that because of facility or institutional access issues that come about based on infection control concerns. Next slide, please. So a lot has been said and written about the influx of patients to post-acute care modalities and whether PAC providers, which includes hospices, are going to be ready. Of significant concern is the availability of PPE, and the reality is that most of it at this point has been allocated to hospitals Even they are having some difficulty acquiring sufficient supply inventories. And for hospices, without adequate supplies, we're going to have difficulty with in-person visits to any patient. That includes those with exposure concerns that cause them to want to limit visits from the hospice team, as well as those with the virus themselves. Now, we know from information released this week that FEMA is stepping in on behalf of skilled nursing facilities, but what I haven't heard is any action by FEMA or any other agency to benefit hospices yet. So we could see some spotty equipment shortages that are going to limit the ability to provide as much in-person care as we would like or as we've done in the past. We're also likely to see staff shortages as clinicians stay home, perhaps with children who are not in school, or perhaps because they are refusing work due to their own infection concerns for themselves or their families. We're going to have to deal with patients who are positive for the virus, which means placement in isolation at home, and training of family members to practice infection control and safe care. And this is going to necessitate more caregiver training, behavior changes on the part of family and immediate caregivers for that patient, probably some retraining even after we do the initial round, not to mention close attention to changes in that patient's overall condition. So in other words, COVID patients may end up requiring more intervention, not less, at a time when staffing resources are stretched very thinly because of illness or barriers to working. And as I mentioned, we could see large numbers of hospice patients who are not discharged from the hospital right away. And hospice clinicians may have trouble getting in to see them, even if they do have full PPE. So that's going to be true as well for patients in skilled nursing facilities, where we know we have access problems all across the country right now, and assisted living. As an adjunct issue that comes from the limits on visitation of patients who are in facilities, we know that some hospices are now having difficulty getting consents or even EOBs, elections of benefits, completed and signed by family members who may be making decisions but who aren't where the patient is and who could even be dispersed themselves due to stay-at-home orders. So at the end of the day, hospice nursing and social work visits are going to drop right along with chaplain visits and aide visits, even though the underlying need for intervention is probably going to hold steady or even increase. So this is where hospices have to find other innovative ways of making sure that their patients are cared for and that the hospice team is able to anticipate what they need as conditions change. Next slide, please. So here's the conundrum. Access to patients is changing. We may not have as much staff as we need, and so we have to find other ways of delivering care. But there are challenges that hospices are going to have to overcome. In fact, last September, Porter Research did a study about hospice adoption of technology designed to strengthen care team collaboration, as well as patient and family engagement. Now, this was clearly way before all the COVID-19 challenges arose, but the research was very telling. And what the researchers learned was that adoption of technology to support care collaboration and family engagement was really quite low among hospice organizations. So here are a couple of key findings from that study when it comes to patient engagement. 86% of patient communication when this study was done occurred via phone or email. Only 2% of that communication was through video chat. Now, when it comes to care team communication, over 50% of the communication among and between the hospice's care team members occurred through email or phone. And only 6% occurred through the use of a mobile app. Now, once again, less availability of staff, steadier increasing patient needs. The answer is going to be interspersing in-person visits with virtual care, even though this type of care has not been widely used by hospice teams, even in the near-term past. And as we add refusals of visits, the need for more care and more contact and virtual services will be not just nice, but really critical to patient care and outcome management. Next slide, please. So as the pandemic progresses, we know that the use of telehealth and remote or virtual visits has really simply exploded. There are all kinds of articles out about this, and sometimes as much as tenfold. And as patients and their families continue to have concerns, it's going to be very likely that the demand will not materially abate. So what we're seeing here is really the resistance to technology evaporating in the face of need for care without the perception of risk. Now, there's one more study that I want to talk to you about, and that was one that was done, sponsored by AARP. It was done at the University of Michigan School of Medicine and directed by the Institute for Healthcare Policy and Innovation there. It was done in late 2019, so before the pandemic arose, but with some very interesting results. We have thought all along that elderly patients were less likely to use technology because a lot of them are still using flip phones and older technology. However, this sample belies a little bit of that. So when they looked at a sample of adults between the ages of 50 and 80, and they questioned those folks about their experience with telehealth or virtual care, only 4% of them indicated that they'd ever experienced any kind of virtual or technology-enabled visit with a healthcare provider. But now, 7 months later, we have explosive growth. And the reason is that we have much more widespread adoption on the part of the patients and families that we're trying to serve of better technology. Now, next slide, please. So all of these things that we've just discussed are converging to force us to find solutions that will enable hospice teams to effectively close the care gaps that we currently have or that we know are coming. So let's talk about some of the problems we need to solve both during the pandemic and certainly afterward. Next slide, please. There are three categories of issues to address: protection, collaboration, and engagement. And for the sake of time, I'm not going to read all of these to you, but what we really need to focus on is protection of our staff, protection of our patients and their families, and very importantly, and I cannot overemphasize this, preservation of patient privacy and protection of their personal medical information. This is something that is really important, particularly to seniors, and do not think for a moment that they're not thinking about this. Even with the waivers that have been put into place that elasticize some of the HIPAA requirements, seniors are still really concerned about this. Now, when it comes to collaboration, we need to be able to facilitate timely care among our own clinicians as well as others who may be serving the patient. Think of DME providers or pharmacies. We need to be able to track and record patient changes in a way that enables us to quickly identify the magnitude of those changes, how significant they might be, and what we need to do to address them. And finally, as we think about engagement, we have three additional challenges here. And these have always been challenges, and they're going to be challenges for a long time. Facilitation of remote, family-initiated conversations around when and how to address health changes. I want hospice providers to think about all of the times that you have had a patient revoke because your nurse or clinician could not respond to a change or a concern quickly enough. So we've got to be able to be faster and better about that. Second, we need to facilitate everyone's understanding of the care plan, of the patient's rights, the patient's responsibilities, very importantly, because those things all figure into the degree to which we will or will not achieve the hospice's goals. And finally, we need to make sure we have the ability to get the required forms that we need so that we can enable billing for the care that we provide. And those are things like those EOBs, change of care notices, and other notices of non-coverage, if it comes to that we are going to need. And we need to be able to sometimes do that without necessarily being in front of the patient when we go through those things. So it's a pretty tall order, but with a few changes in our approach to providing and coordinating care, we can get that job done. Next slide, please. So in order to get this done, we have to change our approach. In order to survive the pandemic and, dare I say, thrive while the pandemic is going on, home-based care providers need to adopt technology now. Now, even Seema Verman, the administrator of CMS this week, said that, and these are her words, the canary is out of the cage. And what she means is that technology-enabled care will be our new normal in the days and months or even years to come. You know, the phone rings right in the middle of things. We need to employ an effective combination of in-person and virtual care to best serve our patients and families. And I believe that the pandemic itself could be, I hope, relatively short-lived. And I certainly hope that we're able to avoid the resurgence that folks are talking about. But whatever the case, the results that affect people's thinking about the care that they receive are going to last a long time. Consequently, even well after the public health emergency ends, patient and family expectations will be different than they were before, and care planning is going to have to be different too. So now is a great time to begin to think about how you can use technology to meet patient needs by supplementing in-person visits with virtual encounters. And now is also the time for me to stop talking. So Melissa, let me hand things off to you so that you can show us how virtual technology can be of benefit not only during the pandemic, but well beyond.
Hey, Sharon, thank you so much for that fantastic information and insight. So we will just keep going here and talk about long-term solutions and how they're needed. So, you know, the good news is that because of the CMS waivers, some organizations, as Sharon has stated, are adopting virtual solutions like Zoom and FaceTime. But there's definitely a few challenges with taking a quick fix approach rather than a long-term solution approach. Namely, number one is the challenge with security. We've all heard of the new term Zoom bombing, right? And hopefully none of us have fallen victim to that, but recent studies have shown that people are increasingly concerned with confidentiality and privacy of their information. And also family member perception of what happens in a Zoom session that gets bombed absolutely undermines confidence in using these tools as a communication vehicle. The other challenge to consider is unreliable connectivity with a video vendor. These could be hiccups in connection that cause audio to be spotty or video to go in and out because these systems are really strained due to the increased volume they're handling now. So there's a greater need now to invest in reliable, secure solutions that are quick to deploy and enable quality care. So this slide is really highlighting what we at Citus consider to be 8 critical requirements for comprehensive virtual patient care. I think many of us think of video visits or video conferencing when we think of virtual care being delivered. almost synonymously, right? But and it's certainly a very important component, but it is just one piece needed to set up to deliver robust virtual patient care. We're actually going to be looking at all of these points that are on this slide in live action actually in a moment, so I won't go into too much depth, but very high level. Secure instant care team messaging. Look, care teams are dispersed and they're remote now, so waiting for an email or a return phone call loses valuable time. And what we know about hospice patients, and not to mention all patients receiving care at home, is that their conditions and needs can and do change very quickly. So at a time when we are doing fewer in-person visits, it's imperative to continually monitor patients, changing conditions. All right, patient and family support. So solutions must enable family members to stay in the loop as care plans change. Families are in the dark right now. They're not able to see their loved ones, but they need to know about the changing conditions that are going on. And as we know, satisfaction with hospice services is directly tied to the satisfaction of the patient's family. And most often that depends on how well we're communicating with the family in the right way at the right time. Secure video sessions, Sharon really hit on that very well. Families are expressing reluctance in having staff enter their loved one's home for fear of exposing them to COVID. Where I live in New York City, there is still a significant lack of PPE, which are making in-person visits more risky. Electronic signature capture. To that end, with not being face-to-face, these interactions are limited, and grabbing signatures to expedite documents such as consents or EOBs, and even capture signatures from physicians on orders, let's say, are really important to do digitally at this time. Custom surveys and forms. We could provide efficient means of gathering information on our census quickly. So these could be questions about symptoms, medication. Many of our clients are actually sending out a COVID-19 screener as part of their daily practice before making a home visit, or even a family satisfaction survey. And of course, educational support. We have to find a way to deliver educational content to patients and families, even though we're not in the same room with them. And we have to be able to broadcast information out in the ever-changing environment. So this would be the ability to instantly share important information, maybe emergency announcements to all patients or their families, or those appointed representatives. And finally, EMR integration. The solution that your organization chooses to adopt cannot operate in a silo outside of the primary system of record. So the solution must be able to capture critical information and send it back to the EMR to be made part of the medical record with two-way interface connectivity. So really a full platform here is what we're talking about. And we'd actually like to take some time now to play out a real life scenario in sort of a simulated environment to show how we can be delivering virtual care through this demonstration. So I'm going to go ahead and switch views real quick here. And let me just orient you very quickly to what you're seeing. This is the Citus Health solution. And over on the desktop side that I'm accessing through Google Chrome, I'm going to be acting as if I'm a staff member. And then you might notice my iPhone is mirrored on the screen. And this is going to be a family member named Victor. Now, families don't have to use a mobile app. We do offer that. They can use the desktop as well. There's no requirement here to do that, but that is certainly an option. So we'll go ahead and log in here. And we're seeing on the left there, we're seeing the staff view on the left, and we are seeing the family view over on the right. And what can happen here is, let's say the family sees that there's a changing condition with mom. They can send in a message. Mom has a rash and, increasing pain, something like that. And what you'll notice is that message is going to come over to the staff side. I might be that nurse that's on call, right? And I can reply back and I can say, please send a pic, right? And that family member can go ahead and use the camera on their phone. And this is secure. It's not saving to the gallery of their phone locally. It's in the cloud, so they can send over this picture over of a rash. And by the way, if the family doesn't speak English, we automatically will translate 93 different languages to English. Now, if I'm the nurse, I can evaluate this rash and say, you know what, I actually want to take a closer look through a video visit. So right within the platform, I can initiate a video chat, which I'm going to do now. We're going to call Mr. Van Ryan here. And we can see he's joining the call. All right, Mr. Van Ryan. Hi there. So I hear mom's pain is increasing and she has a rash. Can I take a look at that rash? Yeah. Yeah. Okay, we're going to reach out to the doctor and see if we can get increasing morphine orders and some orders for some cream for you. So we'll be back in touch.
Great, thank you.
Thanks. All right, so we just took care of that now. Now, directly through the message center, we can actually go ahead and start a message directly with that physician that we just talked about. So I have Dr. Test here, where I might go ahead and reach out to Dr. Test and say, you know, that Mrs. Van Ryan has increased pain, and I might even mention what the current morphine dose is, and you know, Dr. Test will be able to write back and, you know, give me an order perhaps about, you know, what kind of increase in the morphine or something to that effect. So once we receive that, we can get back with the family member and, you know, let them know. So, and you can see right here, Dr. Test has given us the order to increase the morphine. Now, some of these conversations can even be tagged and be made part of the medical record, because you don't want to lose that really important information. Now, if I wrote up that verbal order as a note, what I can actually do is go ahead and send out a signature request to that physician. And the great news is that physician doesn't have to be engaged in the app. We can actually send this out in an appless way. So I'm actually going to do that now. Let's say I have written up this verbal order. All right, I can go ahead and attach that order that I just wrote up, and I'm going to send it to my demo MD right now. And you'll see what's happening here is we're going to do our MD. There he is. There he is. And that order is going to pull up, and basically what we do is we make a template out of this. Now, I'm showing you an order, which is great, but think of this, this can be the EOBs that Sharon was talking about. It could be really anything here. So I'm going to go ahead and hit send and send this out to the doctor. And you'll notice that I am getting on my mobile phone, as a doctor, I am getting a link. Hi, you know, demo, you were sent a document. You'll notice there's no PHI in that, but there is a link that brings me into the secure environment, and it will actually bring up that document that prescriber needs to sign, or if it's the family with the EOB, and there it is. And I'm literally just signing with my finger. Okay. And when it comes back, it is going to come directly back into a work list, and you can see that right here. And that beautiful signature, and we can go ahead and send that directly out back to the EMR if we needed to as well, okay? There's also the ability to send broadcast messages out, as we have discussed. This is the ability to broadcast information about various things as well. That are going on, and we're going to log back in as the family member for a moment. You know, at this point, because Mrs. Van Ryan had a rash, you'll see on the bottom left on my iPhone, there's something called an education center. Well, we might want to send over mom some information about, rashes and skin irritation directly into her digitally here, or it could be information about COVID. A variety of things can be sent. Okay. We also talked about initially when we were going over this, the ability to send forms. So documents are great, EOBs, signatures, but what about forms? These can be things like COVID-19 screeners, or in this case, we'll talk about a satisfaction survey. So you can create maybe the hospice satisfaction surveys that you normally send via paper or over the phone, and you can go ahead and send it to that family member one at a time, or you can do a bulk send as well, and go ahead and send that out, which I'm going to do. And on my mobile phone, I will get a notification letting me know that this has come through. And you can see on the top of my phone there, I have it. And I won't go through the whole survey, but just showing you the ease of it on a mobile device, that I can talk about how great the hospice team is and what, great service that I'm getting from them, and then what I can do is go ahead and submit that. And that will come back over into a work list view, okay? So that you can have that there. So really you can see that the way we think about virtual care, video visits are a part of it, but it's secure messaging with the family, with the care team, the ability to get signatures on documents that are needed for services to begin, the ability to get very important screening information and share educational material. All of this, it is absolutely possible. So I'm going to now go ahead and switch back, since we've done our live practical use cases, and talk there about, why a platform over a point solution. Why consider that? Especially because there are so many point solutions available that address a single problem, but we think that those are rather one-dimensional. That's the challenge with them. They're often operating in a silo, right? So what ends up happening is that we have to cobble together multiple point solutions to accomplish what a platform can do. So maybe it's a signature solution along with a form solution and a video solution and a message solution, all independent of one another, is sort of more common practice. But in order to get the most out of an investment in integrated platform solution, it has to solve multiple challenges along the care continuum while seamlessly integrating back in with the EHR, right? So for example, the Telehealth platform here does accomplish all of those things that we've discussed from A to Z. And we do have an open API that is, based on the CMS FHIR specification, so we can integrate into any EMR. It's also really important that this is easy for patients and families. It's a hard time. It's always hard when your family is sick, and you don't want the technology to be hard. And our customers report back extremely high adoption amongst their patients and caregivers due to the ease of use and faster access to care providers. All right. So what Citus is doing, in response to COVID-19, we know that this pandemic is absolutely straining organizations, and we really want to do our part to help, hospice, palliative care, home health organizations continue to seamlessly deliver care and support to patients virtually. So through the end of May, we're offering our quick launch Care Connect solution. And this will allow for a few of the things that I demonstrated, right? Internal care team messaging, real-time messaging with families, video chat, broadcast messaging. And this is actually an accelerated implementation. Like, time is of the essence, right? So we can stand this up within 48 hours, get you live and connected. So, if you are interested in that, you can certainly take a look on our website. We'll give you information after this on how to do that. So to summarize everything that we've been discussing, providing a comprehensive, care protocol is hard to do during a pandemic, but it's not so hard if we can deploy tools that help us to do it in the way that we discussed. So the fact is, some patients and families are absolutely reluctant to let people into their homes right now. But we don't have to lose that face-to-face interaction, even though we're not doing it in person, right? It can still be intimate, and it can still be that high touch that we're so used to here. As noted on the subjects of the election of benefits, care can't begin until all those documents that establish the patient's and family's wishes are executed for the hospice record, right? So with this electronic signature remote form capability, even people who are not in the same place, maybe the adult son is 300 miles away, right, and is feeling pretty helpless, but we can give that son access to get these things done and started. All right. So what's the ultimate outcome, right, of implementing virtual patient care? Well, we optimize the patient and family experience. We improve surveys and ratings. Remember that hospice satisfaction boils down to how well the hospice did in the eyes of the patient's surviving family members. So having the ability to be connected whenever it's needed will go a long way towards building family satisfaction, even in the middle of a pandemic, okay? So also improving outcomes and cost of care by intervening on changing patient conditions before they escalate, right? And before that patient ends up in the ER. And this will bring the added result of increasing referrals to your organization as well. And increasing productivity. So virtual care enables organizations to service more patients with the same amount of physical resources, which becomes critical. Resources are already scarce, but they're really scarce right now. So that's very important. And finally, we need to prepare for a new world. And we keep hearing this nationally now, in which virtual care becomes required. We're actually hearing that hospitals are preferring to work with agencies that employ virtual care technology. And it really makes sense because they're going to want to know how the patient will be treated before letting them out of the hospital, because they could have some discharge liability if they don't. All right. So if anyone is interested in learning more about the Citus Health offerings and specifically our Care Connect, there's a few ways that you can reach out to us. I do appreciate you watching our live interactive demo. I know that that's not a typical format for a webinar. Certainly appreciate it. And now I'm going to turn it back to Jim.
Thank you very much, Sharon and Melissa, for those insights. We appreciate your time today. We'll now move into our question and answer session, and we do have a few questions from listeners in our queue. First, does Medicare have a security requirement in place that a platform would have to abide by in regards to HIPAA?
Jim, is that a question for Sharon?
Yes, if Sharon feels comfortable answering that one.
Oh, okay. Yeah, I'm happy to. The HIPAA rules is the rule set that governs the privacy and confidentiality of patient information. And it's not Medicare or CMS that enforces those rules. It's actually the Office of Civil Rights. So what we have right now is essentially some elasticity that was granted through a waiver for the duration of the public health emergency with respect to HIPAA privacy and security standards. But once the public health emergency is over, that elasticity goes away, and we will once again be obligated to abide by and uphold the HIPAA standards. So I believe, and Melissa can certainly speak to this more eloquently than I, but the Citus solution is in fact HIPAA compliant right now. So there would be, in essence, no need to worry about that when the public health emergency is over, whereas if we were using FaceTime or Zoom or something like that, the minute the public health emergency is over, we can no longer use those applications.
Thank you. And also, a question for Melissa. At my agency, we've tried implementing patient-facing technologies, but had limited success. How do you get patients and family members to download the app and actually use it?
Yeah, it's absolutely a question we get frequently. The short answer is we remove all barriers to engagement by offering many ways to get connected on Citus Health. It doesn't have to be the mobile app. So for families who are comfortable using mobile apps, they can do that on any smartphone, on any tablet. If they don't want to use that, they can use any computer, or they can use the mobile browser. So we're omni-channel in that way, and the registration process is very simple. They're sent an SMS link, and within 2 to 3 minutes, they are registered and ready to be connected to their providers.
Thank you. And this question perhaps for Sharon. Are electronic signatures approved for hospice consent or election?
Yes. How was that for a short and sweet?
Thank you. And for Melissa, how quickly can Citus Health implement its Care Connect solution, and is it free?
I'll take the second part first. Yes, we are offering it free, no obligations or strings attached for 60 days. So at the end of 60 days, if it accomplished what you needed and you don't want to continue, that's fine. We are doing what we're calling 48-hour quick launch. So from the moment your organization wants to move forward with the Care Connect, we will put together just a standard configuration where you can get started with internal HIPAA secure messaging, messaging with families and patients, video chatting, broadcast messaging, with a standard configuration and webinar based trainings, which of course most things are remote trainings at this point, but it would be 48 hours.
Thank you. And if one of you would like to take this question, I'm not sure who would be, whose purview this would fall under, but can either of you speak to how hospices can bill for virtual visits?
Well, I'll speak to it. At the moment, hospices cannot bill for virtual visits. However, one of the things that we are seeing during the pandemic, particularly for hospices whose patients are in facilities of one kind or another, pick SNFs or assisted living or practically anything, those hospices are actually precluded from visiting those patients unless or until there is a compassionate care situation. And CMS has released very specific guidelines, not once but twice, about that. Nonetheless, hospice teams are having trouble getting into those institutions. However, hospice teams are billing for routine home care for their patients who are in facilities without visits right now, and they are being paid. So what that means in practical terms, and I'll put my compliance hat on here, is that at some point in time, we probably will see ADRs for these periods of time when we're billing but without visits, and we're going to have to be able to demonstrate what care was delivered and the mechanism through which it was delivered, which means virtual care. So we're going to want to be sure that we are, in fact, in touch with those patients frequently, along with their families, and that we are monitoring their care and that we are providing assistance along the lines of what is anticipated by the plan of care. So no, you cannot bill for virtual visits. Yes, they are necessary and very beneficial, not only during the pandemic, but after. And let me just kind of give you a scenario. So when we do compliance audits, very frequently we will see evidence of patients revoking hospice status and going to the hospital because there has been some sort of change in their condition that, at least in the eyes of the family, constitutes an emergency, and they're not able to get in touch quickly with a member of the hospice team who can visit quickly and or intervene on their behalf. That's what causes a lot of revocations. Some people are going to revoke anyway, but others revoke simply because they don't know what else to do to get that patient taken care of. So even though we cannot bill for it now, even as we may be dealing with diminished numbers of in-person visits for perhaps months to come, we can use virtual care to strengthen that link with our patients and their families, and to keep them on service and keep them from revoking, and make sure that they continue to feel as though they're cared for appropriately and adequately, but no billing.
Thank you. And also to Sharon, you had mentioned a post-pandemic new normal. How will virtual patient care help hospices they can actually go back into the home to conduct more in-person visits?
Well, and that's basically what I was alluding to with respect to what CMS has said. So in conjunction with the pandemic, CMS basically came out and acknowledged that they expect that not only hospices, but basically all providers are going to take greater advantage of virtual encounters, telehealth encounters, remote patient monitoring, or even combinations of those. And CMS has now said, through remarks that Seema Verma made this week, that they do not expect that to change materially. So our new normal is going to be interspersing in-person visits with in-between virtual encounters that are designed to strengthen the ties between the hospice team and the family, to make sure that the family has an adequate safety mechanism, so that if they feel as though they need care, they need advice, they need intervention, they have an expeditious way of triggering that request and getting a result. And so I think that will be our new normal as this goes on, because CMS has finally endorsed this as something that's appropriate for post-acute care providers, and they've never really done that in the past.
Thank you. And also to Sharon, can you speak to some of the benefits of virtual care technologies for palliative care teams?
Sure. Well, palliative care is different from hospice, and one of the big differences is that palliative care is a challenge when it comes to getting paid for it. And so consequently, with palliative care, we typically do not visit those patients frequently. Sometimes it's every 3 weeks. Sometimes it actually is a once a month kind of visit. And for some of these patients, they elect palliative care in lieu of hospice because they're not quite ready to take that plunge. But what we know is that they are not expected to improve. And they are being advised, as they move toward palliative care, that therapeutic interventions are probably not going to do them very much good. So palliative care certainly plays a role, and if it were reimbursed a little bit more robustly, I think that we would see more frequency there. But since we don't, and since it isn't, virtual care in between those in-person visits that occur once every 3 weeks or a month can really help to give that patient the confidence that he or she needs, or that the confidence that the family needs about moving on to that next step in the continuum, if in fact that is appropriate for them. The other thing to remember about palliative care is that sometimes patients who are on palliative care are not quite ready for hospice, meaning they're not quite eligible. The prognosis is not yet within that 6-month time frame that the hospice physician is being asked to certify. So palliative care serves as a safety mechanism for those folks as things are progressing. But once again, I see the benefit for virtual encounters to be very great there.
Thank you very much. And those are all the questions that we have in queue. I'd like to thank our presenters, Sharon and Melissa, once again, and thank all of you for joining us this afternoon. We hope you all enjoy the rest of your day. Take care and stay safe.
Thanks.